Guys, this is Mubin. We are talking about the deep venous thrombosis and the Virchow's triangle. The lectures are about pulmonology. However, we are covering this topic over here because 90 to 95% of the emboli from the deep vein thrombi of the legs usually end up in the lungs, and in certain cases, if this is a saddle aneurysm, embolism, they can even cause death. So this is the topic in which we are going to cover this. So let's start. What we'll talk about is the definition of the thrombus and then pathogenesis of the thrombus. We'll talk about the various tests that we can do. We'll look at the management of it. We'll look at the predisposing factors for how this deep venous thrombus can occur. So let's start. First, thrombus. Thrombus is defined as any mass that is attached inside a blood vessel and is composed of coagulation factors, blood cells, and fibrin. There are two types of thrombi. There are arterial thrombi and there are venous thrombi. Arterial thrombi are usually pale in color and their composition usually is white blood cells, platelets, and fibrin. It is difficult for them to trap RBCs because the blood flow is fast. On the other hand, venous compartment is rather sluggish and slow and the blood moves slowly. So usually in the thrombi that develop in the veins, these have a chance to capture the red blood cells as well. So their thrombi, the venous thrombi, are usually dark red in color, and these are called red thrombi, and they have their primary component is the RBCs, red blood cells. They have very few platelets and white blood cells, and they have, of course, coagulation factors, especially the fibrin is present. So that is the basic difference between them. Now, the danger of a venous thrombus is the deep venous thrombus, is the embolism. The emboli from the veins can, so first of all, see that normally the deep venous thrombi occur in the upper part of the leg. Popliteal artery, so let's say this is the, popliteal vein. So let's say this is popliteal vein, femoral vein, in iliac veins, then even it can propagate up to the inferior vena cava. But normally it occurs, the embolism, the thrombus occurs near the valves of the deep veins. Why does it occur over there? Normally the blood flow is sluggish and slow, and this area is usually hypoxic, and the hypoxic injury to the endothelium starts the process of the thrombus formation. And on top of that, if the patient is aged and rather immobile, or the person has been bedridden after maybe a surgery, so we would see some more predisposing factors. If those factors are present, then it becomes easier for these thrombi to form, and once the thrombus starts forming, what they do is something that we call thrombus propagation. That means growth of the thrombus. These thrombi would then start becoming bigger and bigger, and they'll start growing towards the heart. This is called the propagation of a thrombus. Deep venous thrombus usually do not have clinical signs or symptoms. You cannot look at a person and say this person does have the deep venous thrombus or does not have the deep venous thrombus. Deep superficial venous thrombus normally have redness and swelling and tenderness, and they have lots of signs and symptoms that you can see. However, deep venous are rather, they do not show, they're silent. And because of that, one problem is that the pieces of these, the emboli, can separate from them, they can break from them, and these emboli, small or big, can move towards the heart. And because these are veins, of course, as you move toward the heart, the size keeps becoming big, and so embolus actually finds it easy to continue going towards the heart. Once it reaches in the heart, right atrium, it will move to the right ventricle. From the right ventricle, it will go to the pulmonary artery, and from there it will go and seed the lungs. Now, if it is a saddle embolism, which means if it is a large embolus that came in and got stuck here in this bifurcation, normally it gets stuck. If it is a large embolus, it gets stuck at the separation of the pulmonary arteries, and that is where, if the obstruction is more than 60%, then the person can die immediately. That is the saddle embolism. So we will do the embolism and pulmonary embolism separately in a lecture. The discussion now is to talk about this thrombus, deep vein thrombus formation, what is the pathogenesis and how does this happen. Now, so veins that are affected are, we're talking especially about the leg side. So the upper leg veins, popliteal, femoral, iliac, and then the propagation can even enter the inferior vena cava. Tests. So we'll do the pathogenesis a little later. So I'm going to cover the rest of the things that are fast. What are the tests for the deep venous thrombus? Normally, look, how will you know that a patient is predisposed to have a deep venous thrombus? We haven't done the Virchow's triad yet, but the patients with the Virchow triad and factors that are active from the Virchow triad, you should be careful that they may have the deep venous thrombus. For example, you as a surgeon have performed a surgery, knee surgery or hip surgery, and patient's leg has been immobile for a longer period of time. That patient has a chance of developing a deep venous thrombus, and if on top of that the Virchow triad factors are also present, then it becomes even more, the concern increases, the risk increases. So the thing is this, that if you suspect that the patient may have deep venous thrombus, there is a traditional clinical thing to do, and that is the Homan's test. Homan's test is that you have the patient lie down or sit up, and then you dorsiflex the foot with somewhat force, and at the same time you press the calf. So you dorsiflex the foot and you press the calf, and if the patient has the thrombus in the upper leg, the patient would feel pain or discomfort. However, the specificity is about 53%, and sensitivity is 30%, so it's a useless test. On top of that, there is a concern that it is possible that with your mechanical manipulation, you might actually break the thrombus and cause an embolism, which might be very, very dangerous for that patient. However, Homan's test is one test that is done. Useless test, don't do it. The other tests that are more accurate and more specific and more sensitive, of course, are, first of all, because it is a thrombus, you know that on the thrombus, what are we forming? We are forming fibrin polymers, right? And whenever we have the thrombus formation, whenever we have coagulation happening, and whenever we have fibrin forming, there is plasminogen and plasmin as well, and the plasmin would come and try to break down the fibrin. So what will happen is that fibrin degradation products, FDPs, these are here, we'll go there in a second, FDPs are present, and you can test for them, especially D dimers. So one test, if you suspect that the patient may have a deep venous thrombus, again, the DVTs do not have clinical signs or symptoms. If you suspect that they have a DVT, then you can do a D dimer test or fibrin degradation product test. If that test is positive, that still doesn't say that there is a deep venous thrombus. That simply tells you that more exploration is needed. And what do you do more? Now you can do ultrasounds, or you can do MRIs or other such exploratory things to figure out where the thrombus, if there is a thrombus, and where it is. Okay, so now let's look at the pathogenesis, and then we'll do the treatment and how do we handle that. Pathogenesis is, for that we should understand the Virchow's triad. The Virchow's triad is a proposition where we have three things. One is the endothelial dysfunction. Some books say endothelial damage or endothelial denudation, meaning uncovering of the endothelial, removal of the endothelial. That is not entirely true. So endothelial dysfunction and injury, and we'll talk about that in 1 second. That is why I have a summary of the coagulation cascade over here. We'll look at that. That is one. Second is the blood flow disorder, where there may be turbulence or stasis of blood flow. And the third one is the hypercoagulable state. All of these, I love this diagram in Robbins, big Robbins, all of these can lead to thrombosis, especially deep vein thrombus, and especially if multiple factors are present at the same time. What are those factors? Let's look at them, all of them one by one. So endothelial dysfunction can do it, blood turbulence and stasis can do that, hypercoagulable states can do it. So let's look at the endothelial dysfunction and injury. Look, I have a summary of coagulation cascade over here. The best for you is that if you don't remember or recall the coagulation cascade very well, I would recommend that you look at that lecture first. Here is a summary. What happens is there is an intrinsic and extrinsic path. This is the extrinsic path, this is the intrinsic path. Intrinsic path is that when there is a von Willebrand factor present, or the tissue factor present, or there is the plasmin that becomes activated. Actually, not the plasmin that becomes activated, plasmin activation inhibitors when they are present, and we'll talk about that in 1 second. All of those can cause the factor 12A to become active. Again, it's a summary, I'm not doing the coagulation cascade. Factor 12 becomes active. Active factor 12 will cause factor 11 to become active. Active factor 11 activates 9, which activates 10, and factor 10, when that is active, it converts prothrombin to thrombin, which is factor 2. Thrombin then converts fibrinogen to fibrin monomers, which is factor 1. This is one active, and in the presence of active factor 13, fibrin monomers become fibrin polymers and calcium. And these fibrin polymers are the ones that are going to capture the platelets and the red blood cells and create a mesh, and a thrombus will form, a coagulation will occur. The things, so that is the extrinsic pathway. That is the intrinsic pathway. Extrinsic pathway is where tissue factor for some damage. Let's say there is an injury somewhere and the tissue becomes exposed. The tissue factor is present, which is a thromboplastin, right? So tissue factor becomes exposed. That exposure of the tissue factor causes the platelets and then the platelets to adhere there, and that starts a thrombus formation. So the factor 7 becomes active and that activates 10, and this is the extrinsic pathway. Keep this summary in mind. Now, endothelial dysfunction, why do I stress on dysfunction? That is, the reason is this. Endothelial cells, if I make one endothelial cell over here, endothelial cells express on their surfaces a bunch of procoagulant and anticoagulant substances. They expose on their surfaces chemical substances, receptors and ligands that when attached to platelet or attached to other chemical substances can either start the coagulation process or stop the coagulation process. So we have to see what those are. So in this diagram here, the red ones are the ones that are going to stop the coagulation, and the green ones are the ones that are going to start the coagulation. So I'm going to make them here. I'm going to say these green ones will start the coagulation and the red factors will stop the coagulation. Let's talk about the green ones first. One is that within the endothelial cell is the, I'm going to make it green, is the von Willebrand's factor, VWF, right? It is present inside the endothelial cells and it is also present inside the blood circulation. VWF is present inside the endothelium and it is present in the blood circulation as well. Once the VWF is exposed, the platelets bind to that, right, with the GPB1 protein, and that then starts a cascade for the coagulation. So here VWF is activating the cascade. Similarly, tissue factor. So now you can look at me and say, not the tissue factor, endothelial cell cannot have a tissue factor. Normally what happens is the basement membrane, so let's say this is the basement membrane under the endothelial cell, and below that are subendothelial cells, which may be many smooth muscles and other cells. They normally have the tissue factor in them and they express tissue factor on their surfaces. And this is what happens, that is when the endothelium is injured and the blood comes, the factors come in contact with the tissue factor over here, that is how the coagulation starts. However, please remember, endothelial cells in them have tissue factor as well, and they can expose them and express them when these are exposed to some injurious stimulus, for example, bacterial toxins, or for example, other shearing effects, or tumor necrosis factor. These kind of factors can make an endothelial cell, intact endothelial cell, to express tissue factor and start this cascade of coagulation. So another procoagulation mechanism. Similarly, we also have the endothelial cells also express plasmin activation inhibitors, PAIs, PAI on their surface. Plasmin activation inhibitor. So what is the job? Look, what is the job of plasminogen? It becomes plasmin. Plasmin's job is to break down the fibrin polymers. So the coagulation, when that is happening, if it is within the blood vessels and the thrombus is forming, it is plasmin's job to break that microscopic thrombus and not let that happen. However, the endothelial cell, if it is exhibiting plasmin activation inhibitor, which inhibits the formation of plasmin, then the fibrin polymers will not be broken down. So that is also a procoagulant factor. So these are procoagulant factors. What are these? Von Willebrand factor, tissue factor, and plasmin activation factor. The same endothelial cell also expresses other factors which are anticoagulant. What are those? On the surface of the endothelial cell is the thrombomodulin. This is one word, thrombomodulin. Thrombomodulin becomes combined with the active thrombin. Where did the thrombin come from? Through the coagulation cascade. This active thrombin can become bound to thrombomodulin. This complex activates protein C. Protein C, in the presence of protein S, blocks the factor 8 and 5 activation, or it blocks active factors 8 and 5. And factors 8 and 5 are necessary in the coagulation cascade as well. So if these are blocked, will this cascade work? No. So these are anticoagulants. So that is one. Similarly, if you see here, heparin-like molecule. This is a heparin-like molecule. What is that job? What is the job of that molecule? When this molecule interacts with the coagulation cascade factors, so let's say a thrombus is forming here and there are platelets and there are coagulation cascade factors present and there is fibrin. When these factors come in contact with this molecule, what happens is, if the factor is 9 active, 10 active, or thrombin, then heparin-like molecule blocks them all. That also is anticoagulant. It blocks the coagulation cascade. What that means to you is this, that an endothelial cell has a balance of procoagulants and anticoagulants. If for some reason the cell is not functioning correctly. For example, it is sitting in an hypoxic state like here, or it is sitting in a bacterial toxin like sepsis, or it is injured for some other reason, or if the blood flow is low, or we'll see some other factors here. If for any such reason endothelial cell is not functioning correctly, and let's say if it starts making the procoagulants more than the anticoagulants, then the thrombosis would start with the intact endothelium. Or let's say it is not making more procoagulants, but it starts making less anticoagulants. Even then the thrombosis would start with the intact endothelium. So that is the endothelial factors. Then is the blood flow disorders. So now what happens is, look, normally in a blood vessel, let's make a vein over here. This is a vein. Normally in a blood vessel, the blood flow is laminar. What does that mean? Laminar flow means in layers like this. Now laminar flow does this. What happens is that the blood cells, including the platelets, you know that platelets are really dangerous for the coagulation, the start coagulation, they all go in the center, and the plasma becomes marginalized, or the layer of the plasma is on the sides and trapped within the plasma. So if this is the blood vessel wall, then the blood vessel is in contact with the plasma layer, and inside the center of the plasma are the cellular layer. This is the laminar blood flow. What is the benefit of this blood flow? The benefit is that plasma comes in contact with the endothelium more than the platelets, because platelets are in the center of this laminar flow, and that prevents unnecessary thrombosis. However, if for some reason blood flow becomes turbulent or it becomes sluggish, both. Now turbulence can also cause sluggishness. So if the blood flow becomes turbulent and there are eddy currents that are formed, these eddy currents will do a couple of things here. Three things. Number one, the blood behind them will become sluggish because of this pocket. This is like an accident on the road, and the rest of the blood movement will become sluggish. Second, these eddy currents, what are they doing? They are swirling the blood cells, and the blood cells are now going to come in contact with the vessel wall, and platelets will come in contact with the endothelium, and once they come in contact with the endothelium, the coagulation cascade, they might actually bind, and as soon as they bind, coagulation can start. Then, because of the sluggishness, because of the stasis of the blood, the coagulation components, the coagulation factors have more chance to come in contact with the endothelium, and they can start thrombosis. Normally when this happens, in healthy people when this happens, immediately the anticoagulant factors come and they clear that out. However, if the flow is sluggish, the anticoagulants are not going to come in that fast and thrombosis would start. So that is the result of the turbulent blood flow. So here near the valves, blood flow can become turbulent and veins are sluggish anyways. Further sluggishness and hypoxia would start the damage. Final topic for today is the hypercoagulable state. What is that? There are two types of hypercoagulable states. One are called primary and the other are called secondary or acquired. Primary are genetic, and the most common for your tests, for steps and for your clinical practice, remember that we have factor 5 Leiden, or I don't know what is the right spellings for this. What that is that factor 5 is mutated. 60% of the patients, Caucasian patients with deep venous thrombosis, have the factor 5 Leiden. That is why we say that the most common cause of hypercoagulability and causing deep venous thrombosis is the factor 5 Leiden. So what happens is that when factor 5 is abnormal, mutated, then once the factor 5 becomes active, you cannot cleave it. Protein C cannot act on it and cannot break it down. So when it stays active, it continues amplifying the coagulation and thrombosis. So this one is the most important thing and most common cause. Remember that. Then there is possibility of mutated thrombin molecule, and once the thrombin becomes active, it does not become inactive because it is mutated and damaged protein. Similarly, the more rarer form are where patients have less protein C, deficiency of protein C or protein S. Deficiency of that will mean that these proteins cannot block 8A and 5A, and the cascade would continue. So that is the genetic side. Then the secondary side is, this is really important. Here, surgeries. Patient comes in for the knee replacement surgery. Leg is immobilized for a long time. That would cause it. Hip surgery. That would cause it. Prolonged immobilization for other reasons. Aged people, they have their muscle strength is less, plus they're bedridden more. Then pregnancy. Pregnancy is generally hypercoagulable state, one for the stasis of the blood plus the chemical imbalances that occur. Postpartum hypercoagulable state is also very important. Then congestive heart failure, that would make the blood flow sluggish in the legs, and that can cause it. So there are multiple reasons that can cause the sluggishness. So what you as a doctor have to see is that if a patient has, for example, a patient has V. Leiden issue, genetic issue, and patient is going to take a 10 hours flight. In that flight, the patient might sit with the crossed legs and cause compression of the veins. That sluggishness of the stoppage of the blood flow with this issue would trigger the deep vein thrombosis. So it is possible that at the end of or near the end of that, the patient has developed DVT. So multiple factors, when they are present, can predispose the patient towards a DVT. So keep that in mind. One more and final thing, and that is the Trousseau sign. That is also sort of a secondary sign over here. Now this is Trousseau's sign for malignancy, not Trousseau's sign for tetany. Trousseau's sign for malignancy is that the patients with the pancreatic or gastric cancer or adenocarcinomas, they have this secondary aspect before the development, years before the development of the cancers. These cells might start releasing the procoagulant factors, and patient would develop migratory thrombophlebitis, where they may have the thrombosis in the veins, and you can actually palpate that, or arms or face, or migratory thrombophlebitis is developed. That is also possible in case of the cancers or before cancers, and that is called Trousseau sign. Treatment, final thing. Normally you give warfarin and heparin about 2 to 3 months to treat this. Treatment is not to remove it. It is, thrombus cannot be broken down by the anticoagulants, but prevention of forming more thrombus, prevention of organizing and propagating the thrombus is necessary. So for that, warfarin and heparin is given. That is about it. Thank you very much.